Shows that it's recording now.
Yeah, I know. I think I lost the first half.
And the first half hour, it doesn't say record. It wasn't saying recording to the screen.
It wasn't?
No.
Oh.
It just came up. The recording is the recording on the screen just came up.
Okay. If you ever see that it doesn't say it's recording, let me know. I don't know what went wrong. It's not good. Okay, let me just find the chat. Okay. Okay, so we're back in operation. So just, I guess, because the earlier part didn't record, just real quick, we're talking about the 4 categories of shock, right? So categories mean that the types of shock that are inside each category have a common reason why the patient is not having good perfusion. And we said perfusion is the feeding of the cells. So we said in hypovolemic, okay, hypo meaning low in volume, right, that there's some type of fluid loss or fluid problem. So in hemorrhagic form of hypovolemic shock, it's because we lost blood. And in the metabolic form, it's the other fluids that we'll talk about in a second when we get a little further into the lecture. And the most common type of metabolic shock is when somebody has vomiting and diarrhea, it's dehydration. Then we switch to a different category where all the shocks in this category, the sepsis, the anaphylaxis, the neurogenic, and the vasovagal, are caused because the blood vessels suddenly dilate or get bigger, right? So dilation means that a tube gets bigger. If it's your lungs, it's called bronchodilation. If it's your blood vessels, it's called vasodilation. And if the blood vessels get tighter, it's called vasoconstriction, okay? And if it's the air passageways, it's called bronchoconstriction. And we said that as far as the blood vessels go, that the brain controls the diameter of the blood vessels, and it adjusts it based on the pressure that it feels on the walls of those blood vessels, and that there's special nerves called baroreceptors, okay, that send a signal to the brain telling the brain how well stretched certain large blood vessels are. And if they're well stretched, it knows there's plenty of pressure. If they're very floppy, very relaxed, it assumes the pressure is lower and it tries to correct it by shifting fluids around, by secreting chemicals that cause the blood vessels to get tight again and stuff like that. So that all of these 4 types of shocks under the distributive category have a reason why the blood vessels suddenly dilate. So sepsis, we said, is a severe body-wide infection, okay, and that the bacteria, the viruses that are causing the infection cause the blood vessels to relax. And anaphylaxis, we said it's a severe allergic reaction where the immune system, the part of the body that's supposed to protect us, overreacts to something that's really not that bad. And we gave the analogy of a bee sting, that the venom that the bee injects in us in itself is not really that bad for us, okay? And some people get a bee sting, nothing horrible happens. Some people get a bee sting and they almost die, okay? Same thing like somebody eats a peanut, right? So most of us can eat peanuts, there's no problem. Somebody else, for some reason, their immune system has decided that peanut is a horrible thing for them. And in trying to get rid of that peanut from their system, almost kills them in the process. And then anaphylaxis, the 2 main problems that we'll talk about tonight, there's a few others that we'll talk about when we actually, do our class on anaphylaxis, is that the airways constrict. So if your bronchioles constrict, if your larynx constricts, it gets tighter, and you don't want air passageways to get tighter, because if air passageways get tighter, it's harder to get air in, okay? And then the other thing that happens in anaphylaxis is that the blood vessels relax. So this combination of not getting enough air in and dropping your blood pressure because your blood vessels relax is what kills the patient. And we said in anaphylaxis, we have a good treatment, which is the injection of epinephrine into those patients. Then we said there's another category called neurogenic, okay, which is that the spinal cord, the big nerve that connects your brain to the rest of your body, has an injury to it because you've broken your neck. You've somehow caused some type of trauma to your spine, and you're not letting those signals come from the brain to other places of the body. So obviously, if the brain can't send signals to the body does not function. That's why people who have a spinal cord injury are paralyzed and they can't move. The other thing that happens, since we're talking about distributive shock, which is vasodilation, is that the signals to tell your blood vessels to stay tight so the pressure is good don't get to the blood vessels, so they naturally relax and the blood pressures fall. The signals to breathe don't work. So there's a lot of things. Neurogenic shock. That's why somebody who has a spinal cord injury, basically, even with the best of care, typically has a lifespan of about 5 to 10 years after the spinal cord injury. Okay. And then the last category, I think we were talking before everything had to move, is the vasovagal. So in vasovagal, we said that there is a part of your autonomic nervous system. So your autonomic nervous system is the nervous system that runs automatically, whether you're awake or not, because it's controlling things that have to run even when you're sleeping. Okay, your autonomic nervous system has two divisions. The sympathetic tends to be the emergency side of it, where it secretes a chemical called adrenaline, a hormone called adrenaline, that causes everything to speed up and work faster when you have an emergency. So it increases your heart rate, increases your breathing, and makes all the organs of your body work better so you could deal with the emergency. And then it has the other side, which is the brake, right? If the adrenaline is the gas pedal, if the sympathetic is the gas pedal, the parasympathetic is the brake that slows everything down. And sometimes we can trick that nervous system, that parasympathetic side of the autonomic nervous system, to work. And we said that some people do it psychologically by, they see something that bothers them, blood or bad news or, something. And they just actually trick their brain into secreting that chemical. Or it could be because of pressure increasing in their neck because they're getting a massage, or maybe they're choking on something, or because they are straining to go to the toilet. And when they strain to go to the toilet, they're going like this, and they're increasing the pressure in their chest, and it causes that nerve to secrete that chemical. Okay. Now, when that chemical hits the bloodstream, it does two things. It dilates the blood vessels, so that's the vaso side of it. You see vasovagal. It dilates the blood vessels. That's going to drop the pressure. And the vagal side talks about the name of the nerve, which is the vagus nerve. But what the vagus nerve does to the heart rate is it slows down the heart rate. So if you slow down the heart rate too slow and you're dilating the blood vessels, what basically happens is the blood pressure drops. So you need a certain amount of blood getting to your brain, so the brain's getting enough oxygen and sugar to work. And when you drop the pressure too low, okay, you don't get enough blood to the brain, okay, and the brain ceases to function. You lose consciousness or you faint. And then we said the medical term for fainting is syncope, okay, and you then collapse to the ground. Right now, some people collapse to the ground, they don't get injured, and since they're unconscious now, whatever was bothering them, whatever caused the vasovagal reaction doesn't cause it anymore, and they slowly start getting better. We said that to help speed them along, we could put them on some oxygen. We could elevate their legs probably 6 inches, 8 inches off the ground, and they should slowly start feeling better. And I think I finished up by saying that even if we made them feel 100% better, where they say, thank you, I can, you can leave now, we still try to encourage them to go to the hospital, just so that if we misdiagnosed it or if something else is going on, that they're in the hospital and it's not really on us, to deal with it. Okay, so any questions on the distributive? And I see some people ask questions on the chat. So, okay. So the first one says, seeing the word smaller blood vessel means the larger ones don't dilate? No, so usually when you're talking about vasodilation, you are talking about the smaller veins called, the smaller veins called venules, the smaller arteries called arterioles. It's not common to, like, say, dilate your aorta or your pulmonary artery or your, the big ones. So yes, I guess it would be more common that it's the smaller blood vessels in your body. Okay. Then somebody wrote, can the spinal cord get fixed? So I would normally say no, but they are finding ways. I wouldn't necessarily say to fix somebody's spinal cord, but they're finding ways to get the signals to the body. It usually involves somebody going into almost looks like a metal suit, like I'm just trying to think how to describe it, but they basically get fitted into a suit that kind of takes the place of their arms and legs. They don't cut off their arms and legs, and then they connect that suit to their brain. And when their brain, when somebody wants to walk, it sends a signal to this contraption that they're kind of strapped into, and the device starts to move for them, but it's their brain actually controlling it. So there's no real way right now that they figured out to get the spinal cells to regenerate. So once you cut a spinal cord, there's no real way to fix it. Now, some spinal cord injuries are not as bad as others. So when you cut the cord, that's basically it. But sometimes it's swelling or pressure on the cord. And if they can get the swelling or pressure down quick enough so that they could reestablish a blood flow, because remember, if you have pressure, blood is not getting well to the spinal cord. So if they can get the pressure down and reestablish blood flow before the spinal cord has been denied blood for too long, sometimes the patient doesn't have a permanent injury or anything like that. And it said, can vasovagal also happen when a woman is having a baby? Absolutely. And there it's probably a combination of two things. It's pain, okay, because obviously when she's having a baby, it's a very painful procedure, okay? And it's also, that she could be, generating a lot of pressure in the pushing part. Sometimes women, have an additional problem if they've gotten what's called an epidural, an injection in their spine to relax their or to knock out their pain receptors below, say below their diaphragm, so they don't feel the pain of the delivering of the baby. Obviously, when they do that, it also relaxes the blood vessels. So one of the big things when a woman has had an epidural is they want to see that they could actually, stand up on their own and not faint and stuff like that. So that's one of the big, after they have it, before they'll let them go to a regular room and everything like that, they want to make sure that the epidural is worn off. So yes, it can happen to a pregnant woman. It could happen to a constipated person, right? Somebody who's having trouble going to the bathroom. Why is that after spine injury, lifespan is 5 to 10 inches? Because if you can't move and you're stuck in a bed, just like an older person in a nursing home, when your body lays in a position for a long period of time, hours, the blood is not getting distributed well to the skin, right? Where you're pressing into the bed, and you tend to get pressure sores, and they tend to get infected. The other problem is when you're not moving is you don't clean out your lungs as well. You see, like now when people are in the hospital, even when they've had major surgery, they get them up to start walking around so that they start breathing deeply and cleanse out their lungs. They don't develop blood clots in their legs. So, we're not designed as a structure, as a person, to be laying on our back forever, for hours and days and days and days and days. So that's what basically happens, is that people get pneumonias, they get infections and stuff like that. And it's, it's just not a good long-term, situation to be in. So somebody else asked, the term often used, someone blacked out. Is that called syncope? Yes. Okay, the reason they black out is that if you've ever got lightheaded or fainted, is that you actually lose your vision, right, for a brief second. So, like right before you pass out, you lose your vision. That's the blackness they see and stuff like that. So yes, syncope, blacked out, fainting, all the same things. Okay.
And what's the reason why sepsis causes dilation of
the bacteria, the substances that cause the infection, and the substances the body's making to fight the infection is what's causing the vasodilation. And think about it too.
Why dilation?
Vasodilation, right? Because when we're talking distributive, it's all.
Why did they dilate?
That's what. That's the effect. That's the effect that those substances have. That's just what they do. There's no particular.
It's not a way that's how they clean the infection. It's just it automatically dilates.
Right. So actually what happens is when somebody has sepsis and they start to drop their blood pressure, they don't fight the infection as well, because if blood's not flowing well, right, because the pressure's dropped, because the blood vessels are dilated, then the substances in the blood that are going to the site of the infection to fight the infection don't get there. So it's not good for somebody who has an infection to have a low blood pressure, because then they're not going to get the different substances the body has to fight infection to the site of the infection. Now, somebody else asked, why is there this feeling of blacking out when standing too quickly? Good question. So again, when you faint, your brain's not getting what it needs. It's not getting oxygen. It's not getting sugar. So if you were sound asleep and you heard your young child screaming, "Daddy, Daddy," and you jumped up out of bed to run over there, when you were asleep, what's your heart rate? The lowest it is, right? Slow. When your blood pressure, what's your blood pressure when you're asleep? The lowest it is. And that's fine, because you're laying flat on your back. Okay, you're not doing anything, right? So your body's basically in a restful state, and that's you have an adequate blood flow for that situation. Now you suddenly jump up. what has to happen is that the blood vessels in your legs have to start constricting so blood doesn't start flowing down too quickly to your legs. That all takes a couple seconds for the body to, adjust to that. Okay, you have to increase your heart rate a little bit and everything because now you're standing up. And if somebody suddenly jumps up, especially thin people, people who have low blood pressures to start with, women who are on the small side, they don't have a great blood pressure to start with because they're very light. They can faint, okay? And they can injure themselves and they could fall. The other time you've probably all had massive vasodilation, okay, is the mikvah was very hot or that you were in a hot bathtub, okay? And then you decided to quickly get up, stand up, okay? So heat causes blood vessels to vasodilate. So when you're in a mikvah or a bath that's over, say, 100 degrees, 104 degrees or something like that, right? Your blood vessels, even though the hot water is on the outside of your body, okay, your blood vessels dilate. You see that because your skin, right, when you come out is red, and that's all the blood vessels, the blood inside the blood vessels dilating and coming towards the surface. So again, if you suddenly get up, you may feel lightheaded and dizzy, okay? But those are all explainable situations why, somebody feels lightheaded and dizzy. Okay, so any questions on hypovolemic, any questions on distributive? Okay, so now we have two more categories. Cardiogenic, obviously, is shock dealing with the problem of the heart. Now, it doesn't have to be physically the heart itself. I'll explain in a second, but there's different ways people can run into a problem. The most common way that somebody has a problem with their heart not pumping effectively is that they've had a medical emergency called a heart attack, right? The medical term for a heart attack is an acute myocardial infarction. Acute means sudden. Myo means muscle, so myocardial is heart muscle, and infarction means death of. So somebody's got, basically what happened is that across the surface of the heart, if you remember when we were looking at the anatomy of the heart, there's blood vessels that sole purpose is to give the heart the blood it needs, the oxygen and the sugar it needs to stay alive. And those blood vessels are called coronary arteries. When somebody has a heart attack, those coronary arteries get blocked, or not hopefully all of them because the patient would be dead, but one of them gets blocked. And that's when people have bypass surgery or people have angioplasty done to kind of reopen those blood vessels. But if there was damage to the muscle of the heart and it can't pump effectively, then obviously the blood pressure has to drop, because if the pump that's generating the pressure is not pumping effectively, the pressure in the blood vessels has to drop. So one thing is the acute myocardial infarction or heart attack. And again, because people don't like to say all these big words, they abbreviate it AMI. Most people actually cut the A off and just say MI. So you'll hear now when you're, starting to ride on the ambulances and stuff, you'll hear, oh, he had an MI, he had an MI. That's the heart attack. That's the medical way of saying a heart attack. If there's damage to the valves, remember the heart has 4 valves that ensure blood goes in the right direction. So if those valves are sticky and not opening, okay, or they're not closing completely, blood will not flow in the right way, right? Blood has to go in a certain order through the heart for it to work. It has to go from the atriums to the ventricles, from the ventricles to the blood vessels off the ventricles. The right side pumps to the lungs, so it goes into the pulmonary artery, and the left side pumps to the aorta, and it goes to the body, right? So the left ventricle. So if those valves in between all those structures are not working right, then the pressure won't be well. What do we say is interesting about the pulmonary artery from a test question standpoint? That usually arteries are high or low in oxygen. Arteries usually have blood in them that are high or low in oxygen. What do you think?
Low.
What?
Arteries usually have high oxygen.
High.
The pulmonary has low oxygen.
But the pulmonary is the only artery, correct. The pulmonary is the only artery that's low. Why is that? We call it an artery because it's pumping away from the heart, right? It's pumping from the right side of the heart to the lungs. So it's called an artery just because it's pumping away from the heart. The reason it's low is it's taking the deoxygenated blood, right, that's coming back to the body from the inferior and superior vena cava that was all used up and bringing it to the lungs to get oxygen. So that's why it's low. And then, vice versa, then we have a pulmonary vein that's bringing blood from the lungs. And since it's coming from the lungs, it has to be high in oxygen because that's the purpose of the lungs. And it's bringing it back to the left side of the heart, to the left atrium. So that's the only vein that's high in oxygen, okay? So just remember, that's always going to be a test question. Now, somebody asked a question, isn't a cardiac arrest the same as a heart attack? Absolutely not. That was one of the first things we did the first night. We said cardiac arrest means the heart has stopped pumping. So the patient is dead. We said there's 3 forms of cardiac arrest, right? We had the most common is ventricular fibrillation, VFib. That's where the heart, the ventricles, the pumping part of the heart, instead of squeezing and pumping blood, are quivering, shaking, and therefore no blood is functioning. And the other term they'll use for that, somebody who dies from ventricular fibrillation, is sudden cardiac death. And we said the only treatment for ventricular fibrillation is to defibrillate somebody with the AED. And until the AED is there, we want to do CPR to keep the organs perfused. And in between the shocks, we want to do CPR to keep the organs perfused. And then we had two other forms of cardiac arrest. We had asystole, right? So systole means the heart is contracting. Asystole means the heart is doing nothing, and that's flatline. The heart is just stopped. There's no electrical activity. There's no mechanical activity. And then we had PEA, which stood for pulseless electrical activity, which means that when we look at the EKG monitor, there's perfect rhythm on the screen, or at least I shouldn't say perfect, but there's an okay rhythm on the screen that should have a pulse. The patient should be awake and talking. For some reason, the electrical part of the heart is working fine, but the pumping part of the heart is not taking that signal and pumping, right? So those are the three types of cardiac arrest. A heart attack means that somebody has blocked one of the blood vessels that supplies the heart with blood, and the heart is now showing you that by a person having chest pain. Could somebody having a heart attack, an acute myocardial infarction, go into cardiac arrest? Yes. Is it as common for that to happen nowadays as 15, 20 years ago? No, because we have a lot of things we can do for those patients. In fact, an EMT can deliver one of the most important treatments to somebody having a heart attack, which is to make sure that they chew and swallow baby aspirin, because a heart attack is caused by a clot developing, okay, in the blood vessel and blocking the blood flow. And aspirin stops that clot from getting any bigger. So, but anyway, so, you know, that's different reasons why people can go into cardiogenic shock. And then the last one is that people are just not lucky, and they get a cold, they get an infection somewhere in their body. You know, it could be something stupid. They get a toothache, or they get a strep throat. And doesn't mean just because you have an infection in your throat that it can't travel to other places, right? So most of us are lucky. We get an infection in our throat. It stays in our throat. We take some Zithromax and we're fine. Okay, some people are not lucky, and that infection travels. Okay, it could be the silliest thing. You know, I mean, there was not that recently, there was a person who was walking while it was still warm out without any shoes on. They got a small cut on the bottom of their foot and didn't think anything about it. You know, they washed it off and didn't think anything about it. They woke up the next day and their entire leg on that side was red and swollen and, you know, very hot and burning. And, you know, they called the doctor. The doctor said, oh, it sounds like you have an infection. I'll prescribe you antibiotics. Never saw the patient. And unfortunately, it was a massive infection, and the person wound up, you know, losing their leg over it. So, you know, and that's just it was just a matter of luck, or not being lucky for this patient. You know, one, that they got the wound that caused the infection, and two, that their doctor was lazy and didn't have them come in and take a look at it, because if they seen the pictures of what the leg looked like, if any doctor who saw that would have said, you need to get to the hospital now, and you don't need oral antibiotics, you need intravenous antibiotics, and probably needed surgery to actually reopen up the wound and clean it out. And, you know, that wasn't done for this guy. And it got worse and worse, and it swelled so much that it shut the blood flow off to his leg. Okay, so that's the cardiogenic side. Now, is there anything in the world we could do for somebody who goes into shock from cardiogenic? No. We can put them on oxygen. We can keep them warm. We could drive fast to a hospital that has cardiac capability. There's nothing we could do. This is a massive problem. They're going to need, you know, open heart surgery. And to be honest with you, the death rate of somebody who goes into shock from a problem with the heart is very high, you know, approaching over 90%. So it's not, you know, out of all the shocks, it's not a good shock to not that any shock is good, but it's not a, you know, a good shock to have. And then the last one is a rare one, which is called obstructive. So obstruction is blocking, right? When something's obstructing something, an obstruction is something blocking something. So here that there's something blocking the flow of blood through a large blood vessel. So when we're doing distributive, they were the smaller blood vessels. This is a large blood vessel. So we're not going to understand it tonight because we have a lot of things we have to go over, but I'll just show you. One of the things is called a tension. So tension is pressure, right? Pneumothorax. Pneumo means lungs. Thorax, okay, or pneumo means actually air in this situation, okay? And thorax means the chest, right? So where should air be? Air should be in your lungs, not in your chest cavity. Your chest cavity is the cavity that contains your heart, your lungs, your blood vessels. So the air should really be in your lungs. Now somebody has a hole they burst a hole in their lung because, I don't know, they took too deep of a breath or something happened. They burst a hole in their lung. Every time they breathe in, the air escapes out of the hole, but can't go back out when they exhale. So now they take another breath and another breath. And what happens is the air starts to fill up the chest and collapses the lung. Okay. It doesn't stop with collapsing the lung. The pressure continues to build and it starts to push on the heart, starts to push on all the big blood vessels, and it doesn't let the heart pump effectively. Okay. So again, there's nothing we could do on a BLS level. Last night, you know, we were talking about that guy who had the 2x4 in their chest. And I said, if it was higher up where their lungs are, right, that 2x4 was down here, but it was higher up and there was a hole in the person's chest, that we may actually want to seal that hole. But if they got worse when we sealed it, we'd have to unseal it. And that's why, you know, that would be the treatment for somebody who had a hole on the outside of the chest. Here we're saying the hole is actually in the lung. So for the most part, on a, you know, BLS level, that's fast transport to the hospital. Okay. And then a pulmonary embolism is where a blood clot has broken loose in the legs. So this is like you're flying, you know, back from Israel and they won't let you walk around because there's turbulence. So you're sitting in the seat for 8, 10, 12 hours, whatever it takes to fly back. Because blood wasn't circulating well in your legs, the blood started to coagulate or get thick, right? Get sticky, okay? Now you get up, the plane lands, you get up and you start moving around. That blood clot that broke loose starts to float back up towards your heart because blood from your legs goes back up, you know, through your diaphragm up towards your heart. And it makes it into the right side, okay, of your heart, and it makes it through your right atrium into your right ventricle, and it pumps out into the pulmonary artery. And you know the pulmonary artery starts out big, and then it splits to a right and left one, and it goes smaller and smaller and smaller. And eventually we said it winds up turning into a pulmonary capillary that's wrapped around the alveoli. If that blood clot lodges and gets stuck in a blood vessel, there's no blood flow past that. So now what happens is you're not getting as much of the old blood, the blood that doesn't have oxygen that should be coming from the right side of the heart, getting down to the alveoli. It doesn't work. So this is another form, and you may have heard the term a DVT, a deep vein thrombosis, is the term for that blood clot that develops in people's legs when they're not moving around as much as they should. And when it breaks loose, it causes a condition called a pulmonary embolism. So we'll talk about this more when we talk about the different cardiogenic. Again, nothing we could do. These are all, you know, big life-threatening types of situations that need to get to the hospital. So on a BLS level is not anything we could do. Somebody asked a question, would an aspirin help for an AMI cardiogenic shock? Aspirin is the treatment for somebody having a heart attack, yes. Somebody goes into cardiogenic shock because they've already had a heart attack and it's damaged their heart muscle. So, but then it's too late. The time to give them the aspirin is right when they're having the heart attack. Once the damage occurs, the aspirin doesn't help because aspirin only works on not letting the clot get bigger. So you want to give it to them right away. That's why, you know, there's all this public awareness now. If somebody has chest pain, that they need to either take aspirin themselves or call for the ambulance to give them aspirin. It's very, very, very important. Okay.
Pneumothorax tension, you can't, if you puncture a hole
Yes.
through the skin.
So that is the treatment. That is the treatment, right? So in other words, what do you need to do? You need to relieve the pressure, except that they don't let EMTs do that. So, but that
A paramedic could do it?
Yes. But you're absolutely right. If the thorax is overpressurized, the treatment is to get the pressure out. So in the hospital, they do a procedure called a chest tube, where they're taking a very, very, very large needle, almost, you know, as big as a large nail, and sticking it in and hooking it up to a vacuum to suck the pressure out of them. On a paramedic level in the field, we're just sticking a large IV catheter into the chest to relieve the pressure temporarily until they can get into the hospital and do that chest tube. But you're absolutely right. Okay. Okay. So now we've talked about the 4 categories, right? So we said 4 categories. They all lead to shock for different reasons. So in the hypovolemic, there's not enough volume of either blood or fluid. In distributive, the small blood vessels dilate. Again, if they get bigger, the pressure has to drop inside the system, so they're not circulating blood well. Remember, when I say the system, I'm talking the heart, the arteries, the veins, and the capillaries, and the fluid that goes through it, right? So if you're dilating those blood vessels and you're not getting more blood into the system because it has no way to quickly add more blood to your system, the pressure has to drop, okay? And then we had the cardiogenic, where it's the pump problem. And then we had obstruction, where there's a blockage, and this happens to be in larger blood vessels, not smaller ones. Okay, so there's all different types of shock. Again, we're going to spend time talking about each shock, how we treat it. A lot of them we spend a lot of time on. So in other words, we spend a lot on bleeding because we deal with bleeding and we can do something for it. We don't really spend a lot on metabolic because there's nothing we could really do but bring them to the hospital. Out of the distributives, we spend a lot of time on anaphylaxis because we have a treatment for it. We do awareness for, say, sepsis and neurogenic and vasovagal because, well, at least sepsis and neurogenic, because there's not much we could do, but we need to be aware of it so that we transport them to the right hospital in the right way and maybe voice our suspicions, okay, to them. And vasovagal, you know, obviously we talk more about because we see this all the time. You know, it's not uncommon to go on a call where somebody just fainted because they saw blood or got bad news or strained to go on the toilet. So we need to know how to manage that. Just one thing about sepsis is that you're going to go on a lot of calls where it's older patients and the family's going to say they're just not acting right. Okay, that's going to be a story. They're just not acting right. They're more tired. They're not answering. They don't have an appetite. In an older person, it's very easy for infection to develop because their immune system, just like every other system in their body, as they get older, starts to break down. If it's an older female patient, the most common reason why an older female patient develops sepsis it's what's called a urinary tract infection, that they get an infection in the tubes that are bringing the urine out of their body. And it just happens to be in women that the tube is close to the surface of the skin, where in a man you have a penis, so it's a little further away, right? And women are more prone, but little old men can get a urinary tract infection too. But statistically, it's more like, 90% women to 10% men. So you just have to realize that when somebody says to you, my mother, my father, my grandfather, they're just not acting right. It's not enough to say to them, why don't you watch them for a few more hours and see what happens, right? Because maybe when you get there, they perk up a little bit because you're, a fresh face. They haven't seen you, and they're trying to put on their best side and stuff like that. And they perk up a little bit. But just realize that there's a high risk of infection in older people, and that when you have that little old person who's not doing, they're not their normal mental status, they're not their normal way their family's used to, there's obviously something going on. And it's not enough to say, oh, just watch it, and if it continues, call us back. Those people need to go to the hospital. And I'm not saying you would do that, but I mean, again, in the Jewish world, people don't like to send people to the hospital, right? They feel like it's the last thing that has to happen to them. And I don't disagree with them, but to, realize that sometimes people do need to go to the hospital. And it says, somebody just wrote, can I go over the last two shocks? So are we talking cardiogenic and obstructive, I guess? So cardiogenic, we said the problem with the reason a patient goes into shock is not that they're losing fluid, is not that their blood vessels are dilating. This is a problem with the pump, that the heart either can't squeeze effectively, okay, the valves have been damaged somehow, so blood's not flowing in the right direction, or an infection develops in the heart and it's stopping it again from squeezing properly. So the top not squeezing properly, most common reason is they've had a heart attack, and because the muscle's been damaged, it just doesn't squeeze right. Valve problems can happen just because of old age, or could also happen secondary from a heart attack, or infection, okay, develops just like any infection, right? Getting in your heart is pretty rare. So usually that infection starts someplace else in your body and just travels to your heart, okay? Just like people get meningitis, infection in their brain. The infection didn't start in their brain. Their infection started somewhere else in their body and went to their brain. And it's just a matter of luck, really, or not being lucky in that case. So in this case, we said it's oxygen, keep them warm, and transport them to a hospital that has a heart capability, dealing with heart problems, right? And again, this is a type of patient that probably should be going to a Westchester or a Hackensack, more than a Good Sam or a Nyack. Obstructive shock is where the large blood vessels, so you're talking an attention pneumothorax, you're talking the superior and vena cava, and the heart itself were being compressed because of the pressure that was being generated by the collapsed lung leaking air into the chest. In a pulmonary embolism, you're talking about the pulmonary arteries. Those are all large vessels, and they develop a blockage in them for different reasons. In a tension pneumothorax, it's actually a squeezing that's stopping the blood flow, right? We were looking at it over here. So the pressure is pushing on everything, and that's what's stopping the blood flow. In a pulmonary embolism, it's a blood clot that develops someplace else in the body and floated up back to the heart and then was pumped into the pulmonary artery and blocked. Hopefully, if it blocks the entire pulmonary artery, the patient's dead. Usually it floats down, one side and lodges in a smaller blood vessel. Okay, so now the body never lets, somebody just die without trying to fix it or correct it or compensate for it. So the term compensated is to realize there's something going on, but try to do things to stabilize it, right? So when you compensate for something, you're trying to like say, okay, yes, they are bleeding, but there's things the body can do to try to keep the blood pressure up. So that's what we're going to talk about now.
Excuse me a second. Is there a way for an EMT to determine what type of shock it is?
Sure. So that's going to be, so one of the multi-classes, like we just did anatomy is multi-classes. One of the multi-classes we're going to do is called patient assessment. So patient assessment is you being a detective, figuring out what's wrong with the patient. So let's do something simple. Let's do anaphylaxis. So, how are you going to figure out somebody's having an anaphylactic reaction? Most of the times the patient will tell you. In other words, you walk in, they say, I'm allergic to, I was just at a Simca, and somebody says, oh my God, this person's having an allergic reaction. Does anybody have an EpiPen? So the patient was allergic to fish, and there was gefilte fish. Now, they didn't eat it themselves, but it was on the table, and I guess it was enough to generate an allergic reaction in this patient. So one thing is he knew he was allergic to fish, and it was fish there. So that's the first thing he figured out. The second thing is he had what we call all the signs and symptoms of an allergic reaction. So what's signs and symptoms? Signs are something we see, like a traffic sign, and symptoms are something the patient tells you. So what were the signs? He started having hives, right? These bumps on his skin, okay? What are his symptoms? He said, I feel like my throat's closing. So it's early in class, but as we go through every single thing, you're going to see there are clues, right? Signs and symptoms, clues that help gear you into what's wrong with the patient. Now, your EMT class is, going to be what, I don't know, 200 hours, 220 hours. That's not a lot of time, right? I mean, if there's a 40-hour work week, you're going to EMT class for 5 or 6 weeks, technically, right? Full time. A doctor goes to school for, probably 12 years, nurse goes for at least 4 years, right? So you're not having the benefit of, a long-term education. So you're not going to be able to figure out every single thing. But what you have to remember is that there are going to be situations where you don't know what's going on. And the appropriate treatment is to put them in the ambulance and take them to the hospital. It's always wrong to stay on the scene and try to figure something out, right? That's not our purpose. Our purpose is to get people to the hospital in better shape than we found them, and by providing some care, right? So that's why we don't tell people to take taxi cabs to the hospital, okay? In certain situations, it's probably better to take a taxi cab. If somebody was shot and the taxi cab was going to get them to the hospital quicker than the ambulance was, then it's probably better to take a taxi cab, right? So, I mean, that's why there's actually studies looking at people who have real serious problems. It's better for them to go by Uber or ambulance. And what happens a lot of times, unfortunately, is the ambulance plays around. Okay, so now we have to talk about how does the body try to deal with the fact that there's low perfusion, that there's hypoperfusion, right? So the body always tries to compensate, always tries to fix things. And we actually usually have like 1 or 2 ways to do everything. Like, if there's a problem and one way doesn't work, there's usually another way that the body can figure out to work. It just doesn't work as well as the main way of doing stuff, okay? So the term for trying to stabilize something is called compensation, right? So it says here, signs of compensated early shock, which means is the patient does have a problem. They have one of those problems we just talked for an hour about, right? So that definitely is happening, okay? The body says, okay, I recognize there's a problem. How does it recognize there's a problem with flow and pressure? Because it has those nerves, those baroreceptors that are looking for the pressure on the blood vessels. So it knows something's going on, right? And it senses something's going on. It says, okay, I have to deal with this problem. So what does it do? So the first thing is we're going to notice, or the patient's going to notice, some kind of changes. They're going to feel dizzy. They're going to feel weak, right? So there's some change in their mental status. They may start getting nervous because they feel like something's wrong. You've all had a situation where, you felt like something wasn't right in your body. You got what they call nervous or restless. You couldn't stay still. You felt like something was wrong in your body. Then to try to raise the blood pressure, right, to stabilize the situation, what's it going to do? It's going to tell the heart to start beating faster and stronger, squeeze with more force. How does it do that? It stimulates the sympathetic nervous system, and the sympathetic nervous system secretes adrenaline into the bloodstream, right? So it makes the heart starts working harder to try to raise the blood pressure. It's going to tell, the brain's going to tell the diaphragm and the intercostals to start moving air quicker and deeper, bring more air in and do it faster to raise the oxygen level in the body. Okay, so those are some of the compensatory mechanisms you see, right? Some of the things the body does to try to keep blood pressure up. We could even go into it further where it starts to conserve fluid. It starts to release chemicals that constrict the blood vessels, right? So there's a lot of things that happen that try to. But what we could see is we could see the patient's mental status starting to change. We could see them getting tired. We could see them getting nervous. We could see them getting, scared. We could see their heart rate increasing. We could see their respiratory rate increasing. Now, the term delayed capillary refill means that the capillaries we said are towards the surface of the body, okay? So what you would do is you would take your finger and push on their nail. You're going to push the blood out of the capillaries. So when you first lift your finger away, it's the capillary, the underneath the nail is going to look very pale. And then as you take your finger away, you're going to see the blood refill and it's going to get pink. You could do the same thing on your skin, right? You could just push down on your skin for a second, take it away, and you're going to see it goes from pale to pink. That's because we're not in shock. But in somebody who's losing blood, somebody whose blood pressure is low, for whatever the reasons are, we've talked about all the different reasons, they can't get that blood back out into those capillaries as quick. So they have a delayed capillary refill. So now we need to know what's a normal capillary refill. So a normal capillary refill is about 2 seconds, okay, less than 2 seconds, or the time it takes you to say capillary refill. So a delayed capillary refill would be greater than 2 seconds. What was the test question? Okay. The skin, again, as a sign or symptom, becomes pale. Pale means that because there's not a lot of blood getting to the surface of the skin, right? Because the body's trying to keep the blood to the more vital parts, to the lungs and the heart and the kidneys, the skin starts to get pale. It gets cool because there's no warm blood getting to it. And it gets clammy or like a cold sweat on it because I explained to you this once before, we have holes all on our skin throughout our entire body, mostly on our arms and legs, okay? And those holes are called pores, P-O-R-E-S, and they are sweat pores. So that when we're hot, a little bit of fluid comes to the surface of your skin, and then air that's, in the room travels over it, and it cools you. That's called evaporation, okay? Every one of those holes, and there's, hundreds of thousands of them, has a muscle that keeps them closed most of the time, right? They only open up when you need to sweat. When you go into shock, okay, because the blood is not going to the skin, because the skin's not considered a very important place when you're dying, right? Your heart is more important, your lungs, your brain. What happens is there's not as much blood going to the surface of the skin. So those muscles are not getting blood, so they relax, because constriction is the active phase. The tightening is the active phase. If they're not getting the blood, they naturally open up and relax. So now your pore opens up and sweat comes to the surface. It is a cold sweat because you're not getting any warm blood to the area. So it's never ever normal for somebody to have a cold sweat, okay? So somebody that breaks out in a cold sweat has to be taken to the hospital to be evaluated, except if they say to you, I got scared. I was almost in a car accident. Whatever, I saw my life flash in front of me. My kid called me with terrible news. Okay, that's, again, a normal response to being scared, because when you're scared, adrenaline is released. And when adrenaline is released, it shifts around the places that blood go. And one of the places it doesn't let blood go is the skin. And the other place it doesn't let blood go when you sense an emergency is the belly, is the abdomen, is the digestive tract, because it assumes if there's an emergency, you're not going to stop to eat. Okay, which is another reason why when you're scared, you feel like your stomach is rumbling, because if the intestine is not getting enough blood, okay, instead of moving food like it's supposed to, it kind of gets stuck and it starts to shake a little bit, okay? So the term diaphoresis or diaphoretic is the way in medicine we describe a cool, clammy, not a normal skin, right? So it's never normal for somebody to have a cold sweat unless there's an explanation why, an explainable reason why somebody has that cold sweat, like they were scared. Like you go to somebody and says, I almost just had a massive car accident. I saw my, my life flash in front of me, and I feel like my heart's pounding and my head's pounding and everything. That's just the adrenaline that got released because of the fact that they were scared. Okay, the slide disappear, or it's still up there? The slide's still up there?
Still up.
Okay. Okay, now, on the test, they're going to say to you, besides all these signs and symptoms, they're going to say in earlier compensated shock, does the blood pressure stay normal, or does the blood pressure drop? So in shock, usually at some point, the blood pressure is going to drop, right? Because there's not enough blood or there's not enough pressure. But in compensated shock, since the body is doing something to try to compensate, to try to keep everything normal, the blood pressure stays normal, right? So this, in early shock, the blood pressure stays normal. Now, if we are not able to fix the problem and the shock is continuing, okay, what happens is the patient goes into what's called decompensated shock. So it's the opposite, and it's not working anymore. All those things are not really working anymore. And that's called late shock. And the classic difference between early shock and late shock is that the blood pressure starts to drop and the mental status starts to go downward, where they start getting tired and sleepy and unconscious. Okay. All the other things we talked about are still going to be there because the body's still going to try to fight for you. Okay. But the two big changes you see in decompensated shock is the blood pressure starts to drop and the mental status starts to decrease, right? Mental status is how awake you are. So those are the two, main things that you see. Okay. So any questions on anything we started, we talked about so far as shock goes and how the body deals with shock or anything like that? Okay. Oh, before I forget, so if anybody wants Motzei Shabbos, okay, to have some kind of impromptu review class or anything like that, then do me a favor, just text me, before Friday lunchtime. Let me know, and what I'll do is I'll set up a Zoom. And if you can attend, you can attend. If you can't attend, you don't have to attend. The other thing I would just have to know is, like, what time do you guys make out Shabbos? What time would be good to do it? So I don't know exactly what time Shabbos is over, but it's got to be over, 6:30, right? The latest. So what time would be good? What's that?
This week it's over by 6 o'clock, between 5 to 6 to 6.
Okay. So what time would you be done with, all the post-Shabbos affairs and ready to start? And don't tell me 11 o'clock, because I'll be asleep. So somebody wrote 8 o'clock. Is 8 o'clock a fair time? Somebody else wrote 9 o'clock, 11:30. 11:30 ain't happening. So I'll go as far as 9. I'll do 9 to 10 if you're up for that. Is that fair? Okay. Yes. So if anybody wants to, text me, even if it's one person, I'll sign on and we could do, or we could even, if we're doing one person, we could just talk by phone. But I'll set up a Zoom, if anybody has interest in anything they want to go over or anything like that. So just shoot me a text tomorrow just to remind me to set up the Zoom. Okay, so let's finish up with this and we'll be able to get some rest tonight. So again, we said that the body is mainly made up of water. So 60% of the weight of the body is fluid, is water. Okay, now where is that water found? So intracellular is 70% of that 60%, right? So 60% is the total weight of body made up of water. 70% of that water is found inside the cells. So that's kind of hard. Remember, you can't see a cell. A cell is, you need a microscope. They're tiny, but every single one of them is filled, okay, with water. Okay, so the vast majority of the weight of our body is just a fluid floating around in the cells. Okay, 5% of that 60% is the plasma in your blood vessels. That's called intravascular. And then 25% of that 60% is the fluid that the cells are floating in. So you got the little cell that's full of water and it's floating in other water. And I know it's even to me today, it's hard to picture that we have cells just floating around under our skin everywhere. But that's basically what it is. We're just a collection of cells, floating around. Your skin is just your skin is actually an organ. Your skin is the largest organ of your body, right? And it's a collection of cells, skin cells, that make up your organ called skin. And why do we have to have skin? To protect us, to keep us warm, okay, to conserve fluid. So there's, a lot of different things that the skin does. So again, we're mainly water. Why do we need to know this? Because we know that when somebody is deprived of water, they're going to show signs and symptoms. So it says, somebody asked, sweating is from this water. So sweating is from the water that is this water, the interstitial water that's surrounding the cells, yes, okay? So that's where it's from. So when you sweat, you are losing, that's why people who sweat, like somebody's working outside constantly on a very, very hot day, they'll start feeling dizzy and weak because they're losing so much fluid. Okay, now this picture is just basically showing you the same thing we just talked about, that 60% of this person's weight is water and 70%, okay, is the water inside the cells. So 70% of the 60%. is the water inside the cells. Okay, 5% is inside the blood vessels, and 25% is floating around. And again, these are not hard and fast numbers. They're just, rough numbers. Okay, so how does the body adjust the amount of fluid, right? So your brain is monitoring, we said, the pressure in the blood vessels, the baroreceptors, okay? It's also registering how much salt there is floating around the body, okay? So the brain sends a signal to your kidneys. Your kidneys are the organs that kind of filter your blood and clean your blood, and they have the ability to bring fluid into the bloodstream and take fluid out of the bloodstream. So the combination of your brain and kidneys, okay, regulate how thirsty you are. So if your pressure's starting to drop, you'll have an increase of thirst, right? If you have less fluid in your body, you'll feel thirsty and you'll want to drink. So your brain basically sends a signal, your kidneys send a signal to your brain telling your brain that you need more fluid, and your brain tells you you're thirsty, okay? The blood itself, okay, starts to pull fluid from the interstitial fluid surrounding the blood vessels into the bloodstream. Okay, so everything basically has a way of adjusting itself. So again, we talk about that the membrane, the walls of the blood vessels, the walls of the cells are what we call semi-permeable, which means it has the ability for things to go in and out. So everything can get adjusted, okay, again, through the blood vessels, through the blood, through the fluid, okay. Oops. Now, as far as emergencies go, right, disruption in fluid balance, things that are not working right. When you disrupt something, it's not working right. So when we have excessive fluid loss, one way, we call that dehydration. So one way we could have dehydration is somebody has an infection in their body, in their stomach, that's causing them to vomit or have diarrhea. We could have somebody that's outside working in very, very hot environment to the point where they actually sweat so much they get dehydrated. So those are the more common ones. There's more exotic ones, like there's a diabetic emergency where they start having excessive urination. They can't control the urination because their sugar's going very high, and they actually urinate out so much fluid that they get dehydrated. We'll talk about that when we do diabetes. The problem is that on a BLS level, we have no way of replacing that fluid, right? So we just basically have to transport them, because at this point they need the fluid put into their vasculature, into their blood vessels by an IV, okay? And then we have a situation where maybe the fluid is not getting circulated right, or there's too much fluid in the body, like an older person, or maybe they have renal disease and they start to swell up. So you see their ankles swelling and their veins in their neck swelling because they can't handle all this fluid. And you may have heard the term a water pill, right? When people have a problem with they have too much fluid in their body, they give them a medicine called a diuretic, which helps them to urinate, okay? So they start removing the fluid. So if somebody has too much fluid in their body, sometimes that fluid actually starts to leak into the bronchioles and the alveoli, and they feel like they're drowning, right? And that's called pulmonary edema, a congestive heart failure, common medical conditions that we go and treat, right? So what do we do for those patients? Well, on ALS level, we give them medicine to try to get rid of the fluids, but really it's oxygen. So CPAP does a good job in treating those patients, because CPAP forces air back down into the lungs and pushes the fluid back out. But again, you have to feel confident to be able to do it, because the patient, when they're starved for oxygen, when they feel like they're drowning, doesn't really want something over their face, right? They just want to try to gulp air, even though the air doesn't have that much oxygen in it. So you have to kind of convince them to be able to do it. Okay. Somebody wrote, why are people sweating quick? I don't know what you mean by that. Why are people sweating quick? Just, I guess, type something else to explain, and what you mean, and I'll explain it. Okay, so that's fluid problems. So we got just two little other things we have to touch upon, and then we're going to be pretty much done for the night. Okay, so we said that the brain and spinal cord make up your central nervous system, right? And then we had another nervous system called your autonomic nervous system that had the sympathetic and parasympathetic side to it. Your brain and spinal cord, the other day when we were looking at it, we said they're wrapped in a protective layer, and that protective layer is called meninges, okay? And there's 3 different layers to it, and when we talk about head injuries, we're going to talk about different types of bleeding between these different layers and the signs and symptoms that we see. So this is the same picture we saw the other night, where you have your skin, right? Your hair, your skin, then you have your bone, okay? So your periosteum is just the term for the white outer coating of the bone, but you have your whole skull, okay? And actually here it shows how a bone kind of has like a sponge-like You know, even though it's hard, it kind of has this sponge-like effect to it, okay? Then it has the 3 layers, the dura mater, the arachnoid membrane, the pia mater. Those are those meninges, okay? So don't worry about it tonight, but just to get the concept that there's a whole wrapping, and this wrapping goes around the entire brain and the entire spinal cord, because it's your brain and spinal cord made up of the same tissue, the same cells, and it's called your central nervous system. So when somebody has a spinal tap, right, somebody has meningitis and they need to look at the fluid surrounding the brain to see if they can see signs of infection, they're going to go into the space where that fluid is, okay, which is down in here, with a needle and try to draw it out. They're obviously not going to do it in somebody's skull because they don't want to drill a hole in your skull to get that fluid out. So they do it because it's your brain and spinal cord is one continuous system. They do it down in your lower back. Okay, and the interesting thing is that your 33 vertebrae go all the way down to your butt, but your nerve, your spinal cord, only goes down probably 3/4 of the way. So there's the fluid traveling through the canal all the way down to your butt and back up, but the nerve that they would never want to stick a needle into and accidentally possibly paralyze you doesn't go that far down. So there's an area to be able to safely go into the canal and take a little bit of fluid out to put it under a microscope and look at it without actually injuring the patient. Oh, so there's a question somebody asked, why do some people sweat quicker than others? And you know, that's actually a really good question. I don't have the answer to that. So there are people, and I guess it has to do with that, you know, how some people's body, the way it controls their temperature probably reacts in different ways and stuff. So you're right. There are definitely sweaters, okay? And there are some people that don't sweat at all. I don't know. I'd have to look it up and see if there's an explanation on why some people sweat quicker than others, or why some people sweat so easily and stuff like that. But that's a good question. So again, why won't regular drinking water help in dehydration? Somebody asked. So the first thing is, why is the person becoming dehydrated? If they're vomiting and you give them regular water, they're probably just going to vomit more. If they have diarrhea and you're giving them regular water, they're just going to lose it right out their butt. So that's why usually regular water doesn't work, okay? The other thing I think you might be saying is, water doesn't have the substances in it that you're losing when you're losing your normal water inside your body, which is the electrolytes, which is the sodium and the potassium and the calcium and all that stuff. So when you give somebody, let's say somebody who's dehydrated, and as they were losing this, they were vomiting up all this fluid. Out with that fluid came the sodium and the potassium and all the electrolytes, right? So they've lowered, not only have they lowered the fluid level, they lowered the level of the electrolytes in their body, okay? So now you come along and say, oh, let me just give them a glass of water because they lost all this fluid. The problem is that the water doesn't have any of that potassium and sodium in it. So you're actually you're diluting the level of fluid in their body because you're giving them fluid that doesn't contain the electrolytes they actually need. So that's why when, you know, you have your child dehydrated, you know, you give them Pedialyte, because Pedialyte is fluid that contains the electrolytes they need. Now you could artificially make that. You just don't know the right mixtures of it, right? Like how much salt do you put in? How much potassium do you put in and stuff like that? And I'm not saying it's wrong to give somebody some water, or if they're vomiting, you know, if they can keep it down. But long-term, they need something that actually contains the electrolytes in it and stuff like that, okay? Okay, so let's go on. Wait, actually, skip through some stuff here. No. Okay, so how do people have problems with their central nervous system? It's usually trauma. It can be strokes. We'll talk about like medical conditions. We'll talk about traumatic conditions. So again, it's not for tonight. We're going to have, you know, classes on all the different ways that somebody can be injured. So from a traumatic standpoint, you know, falls, car accidents, diving and hitting their head. Okay, trampolines that don't have nets around them, or even trampolines that do have nets on them and the kids bang their heads together because there's 10 kids in there. Okay, from a medical standpoint, a stroke is basically a heart attack in the brain. So it's the same thing where a heart attack, an acute myocardial infarction is a blockage of blood flow to the heart. A stroke is a blockage of blood flow to the brain. They can have infections. We talked about meningitises, encephalitises. There's diseases, right? Multiple sclerosis and all different types of diseases. Or it could just be a simple problem where the patient is a diabetic and they don't have enough sugar getting into their bloodstream because they don't have enough insulin, right? So that's something that possibly we could correct by giving them some sugar. So the other system we have is the endocrine system, right? So the two hormones or chemicals that we talked about in the body for the hormone system, well, actually not two. The one we talked about before was insulin, right? So insulin is a hormone made by the pancreas, which is part of the endocrine system. And we said the purpose of insulin is to allow sugar to leave the bloodstream and go into the cell. So that basically insulin is a key that takes the sugar, unlocks the door to the cell, and lets the sugar get in so that the cell can work and do what it needs to do. So there's no way, I mean, you know, endocrine diseases, there's, you know, probably 100, 150 endocrine diseases, very complicated. I don't even understand all of them and everything like that. That's why there's doctors called endocrinologists. So, but on a BLS level, the one real endocrine emergency we deal with on a regular basis is diabetes. And out of diabetes, the main problem we have is that sometimes people's sugars go too low. And if they're not getting enough sugar to their brain, the brain can't process, can't work, and they become unconscious. So there's a lot of different organs that play a role. Now, your brain plays multiple roles. So it's part of your endocrine system. It also controls breathing. It also controls blood vessel diameter. Your kidneys have a role in cleaning fluids, but they're also an endocrine gland. So that's what they're kind of saying here. But when we talk about endocrine emergencies, we're dealing mainly with the pancreas, which is the organ, well, one of the things it does is it produces insulin. Okay. So here you see your adrenal glands, which are glands that sit up above your kidneys. Okay. So there are two little glands sitting right on your kidneys, and they produce adrenaline, which is the emergency chemical, emergency hormone that makes things speed up when we have an emergency. So that's the chemical of the sympathetic nervous system, right? You may have wives who have either low thyroid problems or high thyroid problems. They're more common in women, okay? Your pituitary gland regulates growth. So sometimes people, when their kids are really, really small and they don't see they're growing, they sometimes have to take medication to stimulate their pituitary gland to send out growth hormone. So, you know, but that's not emergencies typically or stuff like that. So when people have endocrine problems, most of the times the endocrine problem is present at birth. There's a defect and they're, you know, they don't have the right, their endocrine system not working the right way. So like when we talk about diabetes, there's two types. There's type 1 where the kid is born with it. And there's type 2 where they weren't a diabetic for the vast majority of their lives, but they got very fat and the body can't deal with all the sugars they've been eating, and they develop a form of diabetes called type 2, okay, where they do make insulin, but the body actually doesn't listen to the insulin, doesn't let it do what it needs to do anymore. There's, you know, there's a too much of a hormone is Graves' disease, where the thyroid is sending out too much. You ever see people where it looks like their eyes are bulging out of their head? So that's, you know, something you see in Graves' disease. So there's, you know, there's all different types. The only endocrine emergency we really talk about on an EMT level is the insulin problem in diabetes, okay? And then the digestive system, we said the purpose of the digestive system is to bring in the nutrients we need by eating food, right? So you have your esophagus, which is the tube that moves the food from your mouth, okay, to your stomach, okay? Then you have your stomach that starts to break down the food by mixing it with acid and bacteria. It sends it into your intestine. You have a large intestine and small intestine, okay, where in the intestines, it draws out the good stuff, and there's blood vessels that are running alongside the intestine. Again, it diffuses or it leaves the intestine, the good stuff, and goes into the bloodstream and transported to the body. Okay, so that's how everything, including sugar, gets into the bloodstream. How it leaves the bloodstream, okay, is a different way. Okay, so so obviously, if your digestive system is not working well, okay, you're going to have problems, one, with bringing enough water in, because obviously when you drink water, it enters into your bloodstream and your cells by going through your digestive system, right? Because it's going down your mouth into your stomach. And nutrients, which are the foods, right? The sugars and everything like that. Or we could have somebody who's having a problem with bleeding. So gastrointestinal means stomach and intestine bleeding, and that's typically people that have ulcers or weakenings of the linings. And since the linings have blood vessels in them, when the linings of your intestines start to weaken, you start to bleed. So it can be a slow chronic bleed where people don't really have a lot of symptoms other than they probably feel a little tired and weak, and then they go for a blood test. And when they go for a blood test, they could see the levels of the different cells of blood are low. So they know it's a bleeding problem. And since it's not bleeding they can see with their eyes, they assume it's internal bleeding, right? Or sometimes people have, you know, blood vessels that rupture inside their digestive tract and it's very active and a lot of bleeding, and they start to vomit up the blood. So you got bright red blood coming out, or it comes out their rectum, right? So they have blood coming out their bottom part. Again, not as common nowadays as years ago, okay? The most common digestive problem we have is that somebody gets a bacteria or a virus into their digestive tract. It could be because they ate food that wasn't cooked properly, or they ate food that was contaminated from the farm or from the supermarket, like E. coli you hear, and different things like that, or they drank water that wasn't clean. That's why when you go to other countries, right, they don't recommend that you drink water from the faucet, that you only drink bottled water. So when these bacteria or viruses get into our system, the body tries to get rid of it. How does it try to get rid of it? By making you vomit and have diarrhea. And the problem is that in getting rid of it, you're losing so much fluid that you get dehydrated. Okay, so now let's talk about the last body system, and we'll do a quick review and we'll call it a night. So the last system we have left to talk about, okay, is the immune system. The immune system is basically like the army, the police. It protects your body. What is it protecting your body from? Things that should not be in your body, typically viruses and bacteria. So a good, healthy immune system is protecting you from things that should not be in your body. Sometimes we already gave examples where your immune system overreacts. We said anaphylaxis, right, was a situation where your immune system overreacted, okay? In sepsis, it's trying to correct the infection, but in trying to correct the infection, unfortunately, the side effect was the vasodilation and dropping of the blood pressure, okay? But for the most part, the immune system works pretty well, okay? So it's a lot of different substances in your body that identify and know what should be in your body and what shouldn't be in your body. And when it sees something that shouldn't be in your body, it goes and tries to attack it, okay? Now, sometimes your immune system gets overly sensitive, hypersensitive to it, and that's where we have that allergic reaction, or the serious one called anaphylaxis. That's the life-threatening one that we talked about before, that we said that we would administer a drug called epinephrine to that patient to be able to fight it, okay? So when somebody has this life-threatening allergic reaction, there's swelling going on, which is what's closing the airway. There's vasodilation, which is going on, which is dropping the blood vessels, right? So you have swelling of the airway, constriction of the airway. You have vasodilation of the blood vessels. And I wouldn't write can be life-threatening. It is life-threatening. If it's not treated, a severe allergic reaction, anaphylaxis, the patient will die. The fortunate thing is that there is a drug called epinephrine that reverses all these symptoms and stabilizes the patient, okay? And again, patients themselves will have this because they don't have time a lot of times to wait for the ambulance to come to their house. And they invented this concept of an auto-injector, which is basically a syringe that's preloaded with the medication that has a spring that plunges it into the body. And it's a very safe, good way, the best way actually to treat somebody in anaphylaxis. Because of cost, we've gotten away from it. A patient typically doesn't pay for it. A patient has insurance and somebody else pays for it. But for the ambulance, we have to pay for it. So they've gotten away from that, and they've taught EMTs now to give injections. Is it as quick as an auto-injector? Absolutely not. It'd be much better to have an auto-injector than it would be to have to draw up the medication and administer it, but cost is a factor, okay? Okay, so now as review. So just again, the very beginning, we said our body's made up of lots and lots of cells. Cells need to have nutrients, which is at our level, sugar and oxygen, okay, some water, some electrolytes, but it has to have things in there to be able to burn, okay? So the getting of the good things to the cells is called perfusion. When the cells burn them, it's called metabolism. And we said that the good form of metabolism is aerobic metabolism, when we're burning oxygen and sugar together. Going back to yesterday, making a substance called adenosine triphosphate, ATP, which is the true energy molecule of the body. And it burns that ATP, okay? And the cell generates some energy to do what it needs to do, okay? And then by burning that, it has a waste product. And aerobic metabolism, that waste product is carbon dioxide and water, which the body is incapable of getting rid of. If it doesn't have enough, the body doesn't have enough oxygen, it reverts to a different form of metabolism called anaerobic, which means you're making energy with not enough oxygen. You still do make energy, just not enough of it. And the problem there is the waste product, in addition to everything else, is something called lactic acid, which is hard for the body to get rid of and tends to make the body not work efficiently, okay? When we talked about cardiopulmonary, we're saying the heart and the lungs working together, okay, to get oxygen and nutrients to all the cells of the body. And we know that the blood vessel that actually transmits all the good things to the cells and removes all the bad things from the cells are called capillaries. And that the pump is the heart. The pump pumps out into arteries that go to smaller arteries called arterioles. and that in between every arteriole and every small vein called the venule is a very diverse and extensive network of capillaries, okay, that are connecting the artery to the artery to the vein, and it's at the level of those capillaries that everything leaks out of the body that needs to get into the cells, and everything's brought back into the capillaries that needs to leave the cells to be transported to either the lungs to be exhaled or the kidneys to be gotten rid of the body. So when all that's working great, we call it good perfusion. When it's not working good, we call it hypoperfusion or shock. And we said there's a lot of different types of shock tonight that we went over, right? So we said there's 4 big categories. There's hypovolemic shock, where we're losing fluid. If it's blood, it's hemorrhagic, okay? And if we're, witnessing that bleeding, we're gonna try to stop it. If it's fluid other than blood, like somebody's vomiting or somebody's sweating, that's called metabolic shock. We said there is shock caused by the small blood vessels of the body suddenly vasodilating, and now it's harder to pump the blood through, so the pressure drops because the tubes are much bigger. And we had 4 with that. We had sepsis, which is the infection. We had anaphylaxis, which is the severe allergic reaction or the overreaction of the immune system. We had neurogenic, where there was an injury to the spine and the signals to tell the body to keep the blood vessels nice and tight and keep the pressure up or interrupted. And then we had the temporary problem, which was the vasovagal, where the blood vessels are relaxing and the heart is slowing down because of some kind of perceived problem, in the body, whether it be the sight of blood, bad news, or straining to go to the toilet or something like that. And then we had the more exotic ones, or the ones we don't see that often, which are the cardiogenic ones of the heart, where there's a problem with either the pumping action of the heart or the valves in the heart or the heart's being pressed on. And then we had obstructive shock, which there's a blockage in the large blood vessels. And we gave 2 examples, the tension pneumothorax and the pulmonary embolism, where there's either pressure pushing on blood vessels, not letting blood get through, or a blockage or a blood clot in the blood vessel. And we're going to talk about this, again and again and again like that. Okay, so we know the body is mainly water, and that was basically, I thought there was one more slide, but the body is mainly composed of water, and we have to have water to be able to stay alive, okay? So let's see, there's a couple of questions that popped up, and then we'll see if anybody else has any questions. Side question, what makes people overweight? So overweight is taking in more calories. Calories are a measurement of how much nutrients you have or how much things you could burn. So you're taking in more of the food part than you need to burn off. So if you want to lose weight, you have to burn up more calories, because when you have more calories than you need, the body stores it, and it stores it as fat, okay? So that's the product, the problem that we have. In other words, let's say something like sugar, okay? So you need a certain amount of sugar floating around in your bloodstream so that insulin can bring it into your cells, right? Once you have enough sugar, if you continue to eat, that sugar is still getting into the bloodstream, right? So what happens is the body starts to store some of it. So it stores it in case you need it for another day as something called glycogen, which is stored in your liver. So it's just a storage form, a big blob of sugar stored for the day where you can't eat as much that you want to, right? But then you still eat because, you can't control yourself. It then starts storing all that extra sugar as fat, okay? And fat can be reconverted back into sugar, but it's just harder to reconvert it back into sugar. So how you get fat is basically just bringing in too many calories throughout the day for your level of activity, right? And some people, their metabolic clock, in other words, how many calories they need, is different than other people. So some people are more prone, to holding on to the weight, and some people, the problem is that they eat poorly or they just eat too much. Like I was talking to somebody the other day, they wanted to lose weight, and they were talking about how they love fruit, and fruit's healthy, so they don't know why they're gaining weight. Well, fruit is healthy for you. It would be better to eat an apple than it would be to eat a candy bar. But what does fruit have? Sugar and calories. So yes, eating 1 apple a day is fantastic. Eating 5 apples a day is too much. So it's a concept of, burning up the stuff and not taking in enough, not taking in more than you need. So, being physically active, and I'm not saying you have to go out and run or lift weights, just really getting up and walking and moving around. Sitting in class is the worst thing for us, right? We should all be walking around. Some of you are, I'm not, but we should be walking around, and circulating our blood. And, when you walk around, you burn more calories than when you're sitting. Okay. Okay. So we're going to finish up. It's 10 o'clock already, so we'll finish up. Does anybody have any last things they want to review or any questions or anything like that? No, we're good. Okay, so everybody have a good night, have a good Shabbos, have a good weekend. It's going to be beautiful weather. Try to get outside, okay? I'll try to put together a little review quiz at some point coming up. And as far as what you should read next is go to the airway chapter. I don't know what number it is. I think this was 7, so it's probably like 9. There's a little chapter called Lifespan Development. It just talks about that obviously, you know, we go to different stages of life, infant and toddler and child and adolescent and teenager and young adult and old adult. It's whatever. It's not anything important. It just, you know, there's not anything. It's just a chapter in the book. There's not anything on the test on it or anything like that. They just talk about different things you see at different levels of life. If you have time to read it, you know, read it, but it's not a very important, you know, chapter. Okay. So everybody wants to know when you see me in person. You are seeing me in person. I don't know. I don't know. We'll see how things go as far as rate of infection and stuff like that. You guys really want to drive all the way?
The elections are over. The elections are over. We could meet up already.
Do you really want to drive to New Square? Those of you people that live in Monroe and other places and stuff versus doing Zoom?
And we got live using computers?
What's that?
Absolutely, definitely.
Definitely. I don't want to drive. I like sitting in my house. Okay, we'll figure it out. We'll figure it out. Okay, so everybody have a good night. Keep up with the reading. Okay, if you have any questions, I haven't been getting any phone calls. Well, I shouldn't say that. I got a couple of texts today, but I'm really not getting a lot of questions. So, you know, if you have any questions or anything like that,
Frank, that's actually a compliment.
What's that?
It's actually a compliment. You're teaching well. Nobody has questions.
I hope that just it's that everybody's picking it up. You know, I'm always concerned that it's not that. Okay, so everybody have a good night again. Have a good weekend. Stay healthy, and we'll hopefully we'll get some good news with the elections tomorrow, and we'll move forward. Okay, so be well. I'm not sure how much of this taped, so I will upload whatever taped, but I'm not sure how much taped. Okay, so have a good night, everybody.
Good night.
Take care.
Good night.